helping them think through some things and go over some of that. We have obviously a social network, a support network, and that's done in a variety of ways. They can contact their counselor, their old counselor if they want. They can talk to other people who are also dealing with addiction issues. We did split it up so the males were only talking with the males and the females only talking with the females because our clinic sites wanted that, and so that's the way we did that, and I'm glad we did. We also have things like we had team feeds or teams, which is kind of like a Facebook page. And people actually got points if they read certain articles or different things we had in there or listened to personal stories for others. So there was in some ways a kind of a virtual competition. They didn't get real rewards, but rather they got badges and points if they did certain things. And then we had the GPS. You know, almost all of our smartphones now have GPS on them. And what that was really used for is a number of different things. If I was someone who was using the system and went to visit my parents for Thanksgiving, I could go in there and get AA meetings that are in the town, and then I could get directions of how to get to them. So that's one of the ways it was used, a very easy way to use it. The other way we used it is, again, before you left the treatment center, you were given the option of if you wanted to put in the places that you either were your spots where you always went and drank or used drugs, then you could put those in. And so I might, if I were the person, I might say, well, I'm going to put in the village bar because that's where I went every night to drink with my buddies. And so as I came up to the village bar when I'm back in the real world, I might have the phone in my pocket and it vibrates. And I look at it and it says, you know, are you really supposed to be around here? And then if I kind of ignored it and I was still there a little bit later, it could come back and say, Fiona, you know, one of your reasons that you decided not to stop drinking was you wanted to be a better mom or you wanted to be a better dad, whatever the case may be. And you could have a little video clip of your daughter or son on there that actually comes up. So it gives you in the moment the encouragement that you need to hopefully not relapse. So that's a little bit about the system. I'm going to tell you a little bit about the demographics of our people, but I'm going to kind of run through this pretty quickly. We had about 60% males. Mean age was 38. The majority were white. We were at two sites, one in New England area and one in the Midwest, two treatment centers. About 13% African American. Education level was the majority, or not majority, 20% never completed high school, and only 8% had 4-year degrees. The reason they went in treatment varied a lot. They could answer more than one, so that's why it doesn't add up to 100% here. Oddly enough, the majority of them said they went on their own initiative, or at least they checked that. But our sites would say, you know, I don't know that I really agree with that. When you have a court referral to either go to treatment or go to jail, I'm not sure how much that really is your own initiative. But these were the other reasons that people were going in. Other issues that were present at the demographics were over 62% had other drug issues, so it wasn't just alcohol, even though that was our recruitment eligibility, and 47% had other mental health issues. And we asked a question in our pretest of whether they had any emotional or physical trauma that still affected them today, and over 50% said yes to that question. Almost 93% had lost jobs because of their alcohol or drug use, and 88% had lost significant relationships. The only reason I show this slide is to kind of give you an idea of who our people were on the study. And 35% of them went to halfway houses after their time at the treatment center. Many didn't know where they were going to go. And it kind of is a reflection that many of them had kind of burned through family and friends. And so they didn't have places where they could go, like hopefully you or I might be able to, if I got in trouble, could, you know, call my parents or go to my sister or something. I haven't run that out yet, so. Our primary outcomes for the study was to see, compared to the control group, if HS would reduce risky drinking days. And in our study, that was defined for men as 4 or more drinks in a 3-hour period, and for women it was 3 drinks. And so our whole goal was to reduce risky drinking days, as well as to increase complete abstinence and hopefully reduce negative consequences over a 12-month period. People had the HS intervention for 8 months. Those in the control group just got treatment as usual. So if they had some follow-up care, they went to that, or they had the option of going to that. Or if it was just, you're on your own, go out there, then that's what it was. And we did a pre-test to get some of those demographics, and then we had follow-ups, phone calls with everybody at 4, 8, and 12 months. So they had the intervention for 8 months, then we had another 4-month period where we could see if those effects were holding. We actually did phone interviews, and at the 12-month period, we had about just under 79.7% that we actually did. So that was pretty unusual to be able to, with this transient population, really get that sort of response rate. But I would say for the 3 surveys, 4, 8, and 12 months, should take 3 phone calls. On average, it was 20 contacts. We did ask everybody at intake, however, that they give us 2 names of other people we could call if we couldn't reach them on the phone that they gave us. And that was really critical in order to get the follow-up rate that we got. What we did find is that there was a reduction in risky drinking days. And the blue is the control group and the red is the CHES. And you can see at 4, 8, and 12 months, it is all in the direction that we would like. It is actually not significant at the 8-month point, but it is at the 4 and 12, and overall it is significant. But if you look at these numbers, it's kind of like, you know, come on, be real, it's 1.5 days versus 3. But you have to remember that anybody who was abstinent was a 0, as well as anybody who drank and then didn't have any was 0. So the numbers really get stretched out. If you only do it with those people who drank, then the numbers look quite a bit different. But we did it on an intent to treat and included everybody in these. And it was significant, as I mentioned, and it's a .003 level. The secondary primary outcome is increased complete abstinence. And in that, we also found a significant difference. And again, the red is the CHES group. And we see in each case that there was increased abstinence. Now, one thing that I want to say, though, is that what we're doing is when we call them, we ask in the last 30 days. So if we have all these people at the 12 months say they're abstinent, it doesn't mean they're necessarily abstinent that entire time. But in the time block that we called them in the last 30 days, they were abstinent. And this one is slightly different than the risky drinking days, where in the risky drinking days, the 8-month was not significant. In this one, the 4 and 12 is, but the 8 isn't. But overall, again, when you do the overall, it is significant. One of the things that Joseph Kevdar, and excuse me if I've pronounced his name incorrectly, says is that a lot of the apps now that you download people never use. It's a nice shiny new toy, but you never use it. So we were interested in how sticky it was, HS was. And so this is from Pinch Media, and what it does is show after a day how many people are using it. And so of free applications usage over time, just in several days, it drops from only 20% to begin with, and at 90 days, it's just about 1% who are using them. I mean, incredible lack of use. And so we were very pleased when we went to look at our HS data, and this is used by day. So actually, if you only went a third of the way out on our graph to about 90 or 92, we have 40% use there, which is better than day 2 on most of the other apps. And another way to look at this is looking at use by week, the percentage of people who are using the system. So they may not have used it every day, but they used it at least once or several times that week. And we actually have up to 70% who are, or 60% at the end of 8 months. So fortunately, our shiny new toy wasn't so shiny afterwards. It was grubby and well used. So we're very pleased, and that's better than any other either mobile health work that we've done, and we've done some on asthma, as well as our laptop stuff that we've done in the years past. Obviously, there's limitations. It's self-report. We should probably do a urinalysis, but I would almost guarantee we're not going to get the almost 80% rate. The cost of phones is a real issue, and the number of phones that are lost or stolen is an issue, and we really have to look at that and think about that. But you can also go to cost and think, you know, if you keep one of these people out of jail for several days or weeks, you've made up huge amounts of costs. And a number of our people were in jail at various times, either the control group or the CHES. So that's kind of it in a nutshell. Obviously, it was only 2 clinics that we used, and we'd like to get it further. We actually have a research consortium now so that we're getting it out at other clinics, and they're finding similar results that we have from this study. For more information, you can contact us there, and appreciate your time and willingness to be here this morning. Thank you.
So we have time for a few questions. Just come to the mic.
My name is Ann Giles Cleland. Do you have a figure for how much funding it took to run your study?
You know, I really don't right now. I can tell you the phone costs were over the overall study over the time. Let me check on that and get back with you, but it was, you know, a random clinic, a 5-year trial, so it was a fair amount. Yeah.
5 years.
Yeah, to do the development and everything.
Okay. And how long did it take you? So 5 years ago, you developed the app,
Yeah.
and then,
It was out in the field. It was a rolling recruitment, so it was over a couple of years. It was one of the best recruitments we've ever had, which was very nice. So we actually stopped for a while and caught up with ourselves and then started again. But
at another session, someone said, these kinds of trials, your app is obsolete by the time this study is done. How's your app doing?
it's doing great.
Okay.
So it's still there and used. Yep. Anything else? Great.
Okay, thank you, Fiona.
Thank you.
So our next presenter is Gail Rose from the University of Vermont. Gail will be presenting on the efficacy of IVR-based brief intervention for alcohol problems. And they should come up.
Okay.
Slide.
Well, thanks, Bill. Thanks, everybody, for being here. All right, there are my slides. All right. I just want to make sure I knew how to use it. Okay, so I'd also like to begin by acknowledging my research team. Everyone makes a huge contribution to the work that I'll be presenting here. And I also want to very much thank the National Institute on Alcohol Abuse and Alcoholism, who funds our research. So the primary research questions that we're examining in my lab right now are, can automated telephones be used to deliver efficacious screening and brief intervention, which I abbreviate SBI, to primary care patients? And does the pre-visit automated SBI influence the in-office patient-provider-human interaction? So in this talk, I'll be describing a randomized controlled trial that's in progress right now that's designed to test a fully automated SBI program. We're using interactive voice response to deliver the intervention. And I'll also walk through some of the procedural details that we're using to integrate various technologies to make it as human-free as possible. And I'll share some preliminary results. So screening and brief intervention is a tool used in primary care to identify and assist patients whose drinking puts them at risk for other consequences. And we're using the framework of the NIAAA Clinician's Guide to Helping Patients Who Drink Too Much. And our intervention is framed after the 4 steps in the guide. The first step is to ask every patient about drinking. And for those who do drink, to ask a follow-up question, which is a standard question put forward by NIAAA, which is, how many times in the past year have you had 5 or more drinks on one occasion? And that's for men under 65. For women over 60, and those over 65, the question is, how many times in the past year have you had 4 or more drinks on one occasion? Step 2 is to assess for alcohol use disorders. Step 3 is to advise and assist according to the results of the second step, and also according to the patient's readiness to change. If the patient screens negative for an alcohol use disorder, then they're considered at risk for alcohol problems, and the recommendation would be to cut down on drinking. And if the patient screens positive for alcohol use disorder, the recommendation is to quit drinking. And the fourth step is to schedule a follow-up appointment with the primary care provider to reevaluate and determine if there's a need for specialty treatment. There's good evidence from randomized controlled trials that SBI is efficacious and results in better drinking-related outcomes. However, there's also good evidence that it doesn't get done as often as it could be or should be. And so the benefits of SBI are more evident in research than in practice. So there are a few reasons for this. Time is the biggest one, but also providers report being inadequately trained and being uncomfortable talking about alcohol with their patients. And they also often assume that the patients themselves will be uncomfortable talking about it, which isn't necessarily true. In a previous study, we asked people who'd had a brief intervention from their provider who was the one who brought up the topic, and in half of the cases, it was the patient who brought it up, so presumably not necessarily uncomfortable and seeking the information. So then the question becomes, how do we get that needed information and advice to patients if the providers aren't routinely doing it? So there are web and smartphone applications for this, but we've chosen to go low-tech with IVR because it's simple, it's accessible, it's portable, and it's flexible. So in programming the SBI, it was relatively straightforward. We followed the steps of the guide. This shows the branching structure, and I'm putting it up here even though you can't read all the fine print probably, but just to show how it all works. We start with the ask question and the assess, just like in the guide. And then depending on if someone is screens positive for an alcohol use disorder, they're given advice to either quit or cut down. The assist also includes readiness to change, and the person can choose whether they want to cut down or quit, or if they just want to think about it and aren't ready, and then everyone gets routed to follow up with their doctor. Okay. So we ran a feasibility pilot and demonstrated patient acceptability, increased motivation to change as a result of the IVR SBI, and increased patient-initiated consultation with their physician. And our procedural goals then for the randomized trial are first to avoid interference with the clinic routine, which is something we always hear from staff in the clinics when we do interventions in primary care. To do the brief intervention before the person goes in to see their doctor, because that way they can follow up with the doctor if there are things identified through the program that need to be treated professionally and specialty-wise to maximize patient participation in the protocol. So in the next slide, I'm going to step you through the protocol that we're using. The diagram shows the integration of our various technologies, also within the constraints of our human subjects committee. So step one is that an automated process searches the patient registration database to see who's scheduled to come in 2 weeks from now for their appointment. And they're sent a letter automatically that is an opt-out letter. It explains that the clinic is conducting a study in collaboration with the university, that they'll receive a call from a research assistant to explain the study and offer them the chance to participate. But they also have the option of opting out of the study by calling a number ahead of time. The opt-out process is really huge for us because it allows a greater number of people to participate, because participation is sort of the default as opposed to requiring people to actively opt in. And as you know, people who take the step to opt into a study are very different from those who don't. And so the representativeness of our sample is much improved that way. So then 3 days before the visit, up till now, we don't know who these people are. Their privacy is respected. But 3 days before the visit, we receive the contact information for the people who have not opted out of the study yet, and we call to explain the study and invite their participation. Those who are interested are then immediately transferred to the screening, the IVR screening. That's the S of SBI. So first, everyone does the screening. It's a 6-question survey. It asks about pain, smoking, drinking, concern about weight, exercise, and depressed mood. All the screen results are then routed to the electronic medical record unless the patient indicated that they didn't want them to be shared. And then the next step is for the RAs to talk to people who screen positive with the alcohol item and enroll them into the brief intervention trial. Then they get randomized once they transfer into the IVR, and the data are sent directly to us from the IVR system. So other than that letter that goes out, this is a paperless system. It all happens by phone, and it happens before the visit. That's really important, doing it before the visit, because of ethical and patient safety reasons, that if somebody is drinking very heavily, even though the BI cautions against this, but if someone's drinking very heavily, they abruptly stop, they're at risk for alcohol withdrawal. And then assessment-wise, we talk to people. They have their usual care. We talk to them hopefully that day or the next day or two, and then we have them come back in 3 and 6 months for follow-up interviews. I have some results so far. At the time these slides were due, we had screened 676 patients and randomized 63 to the trial, and now we're up to almost 800 screened and 88 randomized as of last night. So to date, our recruitment has been from a suburban clinic in a predominantly white state. The mean age is 48, about half are women, 60% married, 95% identify as Caucasian, 59% have a college degree or higher. And we will be sampling from clinics in more diverse areas as our recruitment continues. So I mentioned earlier that the screening item that we're using is the number of times someone drank 5 or more drinks on one occasion in the past year, or for women and those under 65, the number of times they've drunk that amount in, or 4 or more drinks in the past year. So the NIAAA defines at-risk drinking as if a person exceeds that threshold once in the past year. And I know that may seem like a low threshold to some of you. It certainly does to a lot of our participants. But the threshold is based on item response theory and trying to maximize the sensitivity and specificity of these items for predicting predicting alcohol use disorders. In our sample, the median number of times exceeding threshold was 4, and most people exceeded threshold in the range of 2 to 10 times. We had one, so far I think our maximum response is 200 times in the past year, but that's more of an outlier. At the post-visit interview, we asked for past month drinking using the timeline follow back. And at the 3-month interview, we asked for drinking in the time since the doctor's visit that they had. So this graph shows the mean number of drinks per drinking day based on the 63 participants who completed the baseline interview and the 26 who've to date completed 3 months. So one thing to notice first, it's a very low, whoops, excuse me. How do I go back? Okay, it's a low drinking sample. Average is about 2 to 2.5 drinks. It's below the recommended maximum number of drinks, which is to be expected, not inconsistent with the fact that our threshold is quite low. The second thing to point out is that we have a very low sample right now, sample size, and our goal is to get 750 people randomized to each group, so we're pretty early in the process. And then there is no significant difference between these numbers. But again, it's a small sample, so hopefully we'll see more difference once we recruit a more diverse sample. But it's encouraging that it's going in the right direction. So I mentioned at the beginning that our second objective of the study was to determine the influence that the IVR SBI might have on the patient-provider interaction in the visit. Someone else said at this conference that the point of using technology is to give the provider more time to interact with their patient, and that's really sort of what we're aiming to do as well. So what I've got next is some data from the post-visit interview where patients were asked to describe what happened in the interview regarding their conversation with their doctor. So we had the black is experimental group, white is control group. The overall 56% of patients who were randomized to receive the IVR SBI talked to their doctor about alcohol versus 48% of those in the control group. So then we asked these people who started the conversation and did your doctor make a recommendation about your drinking. So 41% of the experimental group participants said that they raised the topic versus 33% in the control group. And then 39% of experimental participants said the doctor made a specific recommendation versus 27% in the control group. Again, small sample. We don't know if these are enduring effects, but again, they're in the right direction, and what we hope and expect will happen as a result of the pre-visit brief intervention. So, in conclusion, we feel that the IVR has a lot of potential in this context because this integration with the electronic medical record opens the door to other uses. So, for example, there could be a brief intervention or a patient education module developed for each of the items on the screen. So we could have a smoking-related one, a weight loss one, pain control, depression, you name it. It's low-tech and easy to use. And it's relatively low cost. I mean, it depends on what you're comparing it to. It costs us about $20,000 we used an outside vendor to develop it, and it includes all the hosting costs for 3 years of data collection. And of course, these are primarily upfront costs. Once the funding goes away, the product and the infrastructure will still exist, and with each additional user, of course, the relative incremental cost continues to go down. So validity is higher with an IVR because we're assured that the screening and the brief intervention occurs the same way every time, whereas with human doctors, they're idiosyncratic in terms of how often and how thoroughly they do a brief intervention. The automated screening and brief intervention saves the provider's time if it's done in advance of the appointment, because that way the patient comes in armed with some screening, some education. The doctor can then take the time to tailor their message to whatever the specific health circumstances are. And the public health impact of any intervention, of course, is related to how widely it's implemented. And a brief intervention by a doctor or by an IVR are clearly not mutually exclusive, but I would argue that of the two of them, the IVR BI has the potential for broader implementation than what physicians have to date been able to manage given their high demands on their schedule. And I'm happy to take your questions.
I was just wondering, with your alcohol questions, you showed that there was a number of drinks per day in the last month.
Right.
How do you deal with recall bias? And also, were you taking an average? How are they answering that question?
Okay, we use the timeline follow-back, which is a validated method of assessing drinks on a daily basis over the past period of time. So we literally get a calendar out. We ask them to identify certain anchor points of what may have happened during that month, you know, what their work schedule is, and try to prompt their memory as much as possible. And then we literally ask them, how much did you drink on this day, this day, this day? And yes, it's an average of those days.
Hello, I just had a quick question regarding your post-visit interview. When and how was that conducted? Was it by telephone within the 30 days of the appointment? Was it the same day? Can you give me a little feedback?
Yeah, when someone enrolled in the study and agreed to be randomized, at that time we scheduled that visit, well, not a visit, that telephone call. So it was by phone live with a research assistant. Ideally, it was later that night after their appointment, or the next day, and that was when it was scheduled. But of course, it happens sometimes when people don't meet their appointment. And so, I mean, our goal is to get it within 1 week of the visit.
Other questions?
Thanks.
Okay. Thank you, Gail.
You're welcome.
So our next presenter is Trevor Van Mierlo from Evolution Health. He's going to be presenting on, I'll text you if there's a problem, how Canadian Cancer Society used live text chat to help young adults quit smoking.
Thanks very much. I'd also like to extend my thanks to our research team, our development team in the Canadian Cancer Society Quebec division for this very successful phased project. Now, the title of this talk is how the Canadian Cancer Society used live text chat to help young adults. But based on the themes and the needs of this conference, I think it would have been best phrased how and why. How? Well, I'm going to talk about a development process that we utilize that's not mentioned much in this conference called Agile. And why? It's because the actual young adults in this phased research project told us that this is exactly what they wanted. Okay, so I'm going to, again, frame this talk in around Agile technology and the Agile development methodology through discussing reaching special populations, in this case, young adult French smokers, the phased approach that we took to bringing evidence-based health development to life, and the winning formula that we've found that is enabled to bring these digital health programs beyond the lab. We worked with a number of institutions and organizations in a number of areas in fairly well-known e-health and mHealth interventions that have been quite successful over the past 10 years. So who we are? Well, the Canadian Cancer Society, is like the American Cancer Society, except they're in Canada. The thing that's important to know about the Canadian Cancer Society is that each province has their own budget. So even though they're a national organization, each of them have their own mission and, I mean, again, their own sources of funding. So as you can imagine that Quebec is a primarily French-speaking, or is a French-speaking province, so they have very, very different needs than the rest of the provinces. Evolution Health, that's my company. We've been around since 2000. We have a software platform called Barigi, which means bridge in Japanese, and we bridge traditional evidence-based healthcare with Healthcare 3.0. And we do that for a number of conditions, and we have web, mobile, social networking, and expert support tools. So setting the stage. So I have a picture of a Montreal smoked meat sandwich there. Let's pretend we're in Montreal or Quebec City. One thing that you'd notice if you're in Quebec is that a lot of people smoke. 18% of Canadians smoke, but 23% of Quebecers smoke. And one thing that's really disturbing is that smoking among young adults, for some reason, is on the rise. That's kind of in opposition to the rest of the statistics that we have around the world. So it is a big problem, and it's going to cause more problems in the future. On the other hand, a lot of people in Canada use mobile phones and text messaging. So I'm sure I don't have to convince all of you that a possible solution to this problem is to use text messaging or mHealth solutions. Okay, so what is SMAT? And this is probably the most important slide that I'm going to present. SMAT, when translated into English, means short messaging against tobacco. And I'm told that that actually translates very well. It's quite cool. It's not as boring as the English version. But how did SMAT come about? Well, back when we started in 2000, we had an email program that was algorithmic based, and it sent inspirational and targeted messages to people through email. Around 2002, we decided to do an experiment. We said, what if we take these emails and truncate them and try to deliver them through text messaging? Would that actually work? And we're a research and development company, so we took the expense to put that together, and a lot of people told us, people are never going to use the mobile phone for healthcare purposes. Are you crazy? You're attaching health messages to their actual phone number. So I think we've kind of proved that wrong. So what we did is we took that email program, we created the mHealth platform, did some studies, had some positive results, and then the Canadian Cancer Society Ontario division, again, different budget, essentially different organization, they came to us and said, we would like to have a text messaging program for Ontario citizens. The problem is we need to have it in both English and French. Just by the rules and regulations in Canada, you need to have everything that you provide from a healthcare perspective in English and French. So we built that, and we did a study, and we presented the data here, I think, 2 years ago, and we actually won an award. It was given to me, a Meritorious New Investigator Award, but I was just the person on the front. I mean, all of the research was done by the research people. So we were pretty happy with that, and we got some press out of it. So Quebec came to us. The Canadian Cancer Society Quebec division. And they said, we'd really, really like to take that program and adapt it for a French population. And if there's any Canadians in the audience, if there's any people here from Quebec, you will know that what works in French in Ontario does not work in French in Quebec. And if you want to turn off any Quebecers, send them something that's been translated and they'll know right away. So we underwent a really rigorous process in which we used a lot of interviews with youth, and there was two major outcomes. We've done a lot of programs with youth, but the two major outcomes from this process was treat us like adults, don't try to use cool words, and don't try to give us everything that's available mobile. Just give us the simplest, most easy things to use that can apply to our specific situation. So instead of offering them a very expensive program with videos and all types of difficult algorithms, we gave them the most basic intervention that we could. So this was SMAT phase 1, and the basic intervention only involved proactive and reactive text messaging. And again, this was a pilot. So about a little over 1,000 text messages were sent to 183 users, sent by 183 users. But this is where it gets really cool. 697 contained a keyword like the program was intended, and there's the keywords, and their frequency. But when we sat back and looked at the data, 398 weren't keywords, they were conversations. So we thought, why would people engage in a conversation with a keyword service? Didn't make sense to us. But in the further analysis, we found that 40% said they wish they could have texted with a live person. So this is the Agile Development methodology. What we do is we build things based on need rather than building from ideal. So this is, we invented something with the Canadian Cancer Society called TACHI, which is text and chat integrated. And you probably can't read the interface. If you'd like a live demo, please feel free to contact me. What happens is that they have the quit specialist sitting at the desk answering the phones, but they also have computer monitors, so if someone texts the quit service, a window will pop up. And the window will be populated by all of the demographics from the smoker, as well as their quit date, as well as their past chat history. We also have a bank of standard responses that they can search and push over and modify and send. And we were surprised at how successful this program was with this specific special population. But then again, we shouldn't be so surprised because it's what they asked for. So again, that was an add-on. TACHI was an add-on. We still had the proactive, the reactive, and then we added TACHI. So in phase 2, the study period was September 2011 to June 2012. There were 994 participants. 51% were male. 40% were between the ages of 18 and 24, which is great because we're actually targeting this hard-to-reach population. And they were heavy smokers. They smoked on average 17 cigarettes per day. We sent out about 43,000 algorithm-based proactive text messages, and again, these are based on quit dates and other algorithms. 65% used the reactive keyword service. And the most popular keywords were distraction, craving, and stress. It's really great for us to track the keywords that are coming in because we're able then to add to the bank of responses that we have based on frequency of use. Now, we didn't think we'd have this many, but we had almost 1,100 text chats, and 48% of those text chats were with men, so and young men. And perhaps the culture's changing. Or maybe, I don't know, maybe in Quebec they're more advanced, but you know, I'm a guy, and my wife gets mad at me all the time because I will not stop the car and ask for directions at a gas station. I don't like to talk to someone on the phone and to order pizza or takeout. I don't even like to answer the door. I'm just a typical guy's guy in that situation, but you know, and I'm not sure why that phenomenon happens. Maybe we feel some type of humiliation when dealing with someone face-to-face. But this is a great, TACHI is great because you can just text chat anytime you want, and you're not actually facing someone or speaking to them on the phone. So again, I don't have the reasons why this is working out so well. To me, it's just a very, very interesting statistic, and I'd love to chat with people to get some more insights on why this is actually working with this very, very hard-to-reach population. So as far as quantitative results, so we've done a lot of studies. We know that attrition is a huge problem. Traditionally in the past, what we did is we had multiple methods for getting self-report data, telephone, surveys, web. This time we just said we're going to use the phone. The phone seemed to be working, so we sent a 3-month follow-up text. In the last 7 days, have you smoked a cigarette or cigarello, even just a puff? And this was in French, not English, by the way. Press 1 for yes or 2 for no. Very simple. We had a 58% response rate, which I think is really, really great. And the people who answered no were 170. So that's the intent to treat should actually be 18%. And again, this is self-report. This is not a randomized controlled trial. But for such a low-cost intervention, such a simple intervention, that is going to grow in sophistication, we're very, very happy with the result that we have. Now, the Canadian Cancer Society Quebec Division also hired an outside company to do some qualitative analysis through telephone and web. 71%, and they had 373 respondents, which is much less than our phone survey. Interesting. Why are people not wanting to pick up the phone and talk to people? 71% wanted to continue to receive the messages. Now, 62% said it was useful in their quit attempt, and 95% they would recommend the SMAT service. So what confuses me is that 62%. It doesn't seem to jive with the rest of the numbers, but I just thought I'd present it. And what we're more interested in learning is where we're going wrong or where we can improve, and it's just a little unsettling to see that number. But who knows? Excuse me. So for all of us who've been building eHealth and mHealth interventions for a while, here's some more, backwards. We all know that research scientists and developers make strange bedfellows. It's very, very difficult to take people with two different mindsets and two different types of training and put them in a room and get them to develop a product. You can do this through using Agile, and we call this, with the right project managers and the right leadership, a marriage made in geek heaven. So we think this kind of stuff is cool. Imagine having R2-D2 as your flower girl. Fantastic. So the thing with Agile, though, and why a lot of researchers have a problem with it, is because there's two inherent risks. So the first is you can't manage in a traditional way. Throw your Gantt charts out. It's not going to work. You're going to have a budget, and you're not going to be able to create specific milestones with specific dates. The methodology doesn't work that way. And second, you go on a journey of discovery. So when we were developing that interface that I showed you, which was TACHI, the quit specialists who were also involved in the process realized that, there's a problem here. I have 5 tabs open. I have 5 conversations going on. When smoker number 2 texts me, I don't know that there's a text that's come in, and I often ignore them. So we had to go back to the development shop and make sure that we made the tab flash. So we're able to respond to these smokers in a timely fashion, because nothing's worse when you're in an emergency situation or a relapse situation and no one answers you. So again, that came out of the Agile development methodology, and that's not something that you can determine at the beginning of a project plan. And that's why a lot of the programs that we work with end up being successful, because of this interdisciplinary development methodology. And I notice I don't have a thank you slide, but I'd like to thank everybody. And if you have any questions, please feel free to email me directly or chat with me afterwards, or ask questions now.
Thank you, Trevor.
Thank you.
So, questions for Trevor?
Hi.
Hi.
I was thinking about your 62% that you were questioning, and then, so I had a couple of questions. Was your sample comprised of people who identified that they wanted to quit, or just that they were heavy smokers?
That they wanted to quit.
Okay. And had they had prior quit attempts?
I don't have that data with me. It was a fairly extensive study. I'm probably sure that the average smoker has quit 1 or 2 times, or at least tried before. So
Right. I was just wondering if they were comparing this to some other prior quit attempt and the methods they had used for that.
I never thought of that. That's a great idea. And I'll make sure to tell the Canadian Cancer Society. Thank you for that.
Do you have advice for the mobile health development world trying to make health apps and use the Agile technique? Or we have a pilot study, and I can't change the software. So I cannot iterate, I cannot modify, I cannot, because it's in a study.
Well,
so that isn't Agile, and it's really, really inhibiting.
That's why we build our own software. So, and that's why it's good to partner sometimes with other organizations that do have existing pieces of technology. A lot of times there's people who you think are your competitors, and they're not your competitors. They can actually be your partners. So buying or using off-the-shelf types of applications has a tremendous amount of limitations, especially in healthcare, because we're dealing with a very, very special population and very, very special indications that require tweaks that can't be necessarily made with traditional software. So as far as developing your app, I would do what we do. This is now coming out in an app. We started off with just text. We're now going to app, and the other enhancement we're making is we have support communities. So we're pulling in the support communities to the actual app. So again, when you're doing Agile, it's based on need and unique ideas that will meet those needs, rather than trying to develop this beautiful intervention in the sky that we think everyone's going to use, but it'll just be too complicated and too expensive. Hope
Thank
that
you.
helps.
Can I just, Trevor, let me just add, I think this is a real struggle in the field, and one of the things that I don't think we use enough that fits with an agile or iterative sort of incremental design method is using some smaller sort of series of N of 1 trials, so that we roll out a process. We tested on 4 or 5 people in a small but intensive longitudinal data set, get some data, move to the next version, and kind of more rapidly sort of move along. It fits certainly better with an agile
I
development
absolutely
process.
agree, because this is going province-wide in Quebec. That's the next step.
Hi, I'm Sarah Chow with the American Legacy Foundation, and I had a question about, I guess, the staffing that you had used for this interactive texting. Because usually I feel like most SMS programs have automatic keyword texting because they don't want to have people sitting there talking to someone. So I just wanted to see, I think the TACHI program looks great because it makes it easier for you to interact with multiple people at the same time.
Right.
But since you had a fairly large, group that you were texting with, I just wanted to see how many people you had used for this interactive texting, and I guess what the times were like, when it was available. Was it 24 hours or was it during certain hours?
The quiz specialists use it when they were actually working. But they could while they could only talk to one person at a time on the telephone, I think they had 5 or 6 text chats going at once. So, I also have an MBA, so that's where the MBA side of my mind gets really excited, because when you take a look at the cost efficiency of telephone specialists, it really, they become much more useful because they're dealing with that many more people. Plus, we collect the data. Every single interaction that goes on, we have that data for future analysis, which again allows us through the Agile development process to improve the program and sort of analyze their productivity.
So one last question.
Thank you. It's a two-part question. One, when the live chat is occurring, I noticed in the example, the recommendation was to get out of the bar because there was...
So you can read French. Wasn't it in French?
No, it was in English.
was it in
for
English?
us.
Okay, sorry.
And so my first part of the question is, I'm not aware of the smoke-free policies in Quebec, and so I'm wondering if the live chat encouraged them to go to a nearby bar that had smoke-free policy, and then the second part of it was the theoretical framework that you're using for the live chat messaging, the
Sure,
responses
sure.
or the suggestions that are provided.
The theory is based in, brief intervention, motivational interviewing, stages of change. Whenever alcohol is involved, we tell people to get away as fast as you can. We'd never recommend them to go to another bar. In Quebec, I think there's probably some bars that you can get away with smoking in, or some clubs. So again, it's a very special population that you need to apply the theory to, but in a very special way. The Quebec Canadian Cancer Society is very aware of the theoretical constructs that need to be behind the actual intervention, but they're also very aware that Quebecers think and act and feel differently. So it's an adaptation that you need to make.
Okay. Thank you, Trevor.
You're welcome.
So our next presenter is Kwang-Yi Wen from the Fox Chase Cancer Center. She'll be presenting on preventing postpartum smoking relapse, a C-chip-based text messaging intervention.
Thank you. Glad to be here. So I will be talking about the development process and a little bit preliminary result of an intervention that we designed to help postpartum women to stay smoke-free. A little bit background about this very unique population. So we know smoking is bad, and pregnant women continue smoking, experience immediate adverse outcome, such as preterm delivery. Fortunately, we see relatively high quitting rate among this population, spontaneous quitting rate, and our study do show that intervention work. However, smoking relapse rate immediately after childbirth is really high, and we know that secondhand smoke contribute many problems among children, as well as 6,000 annually death among children under 5 years old. And just a recent meta-analysis report that very limited intervention for these postpartum populations. And the smoking prevalence and the quitting rate are even worse among underserved socially disadvantaged populations. From one of our previous studies that using smoking cessation clinical counseling, we found that the intervention might work if they came to the counseling. The problem is they don't come. And in addition to the psychosocial risk factor, we found the major practical barrier that they reported to us is the transportation, the child care support that they don't have to support it to attend in-person counseling. But our observation with that population we work with, they always have a cell phone rather than landline that was disconnected all the time, that we could not reach them. That led to our current study that looking at pilot test a 1-month text message intervention that was theory guided and also developed through a systematic formative evaluation process, and also working with the Women and Infant Children Clinic in Philadelphia to really target a group of very ethnically diverse and low-income women. So this is the flow of the study. So as you can see, really emphasize the formal evaluation process of the development. Our research team has a lot of experience in developing patient education material, either brochure or web-based program. But this is our first text message intervention. And we want to make sure the text, the content we provide through within that limited character work. So we start with the intervention developed with the near-assessment interview with the target population, and the message were developed based on the theory we use, which are further evaluated by health literacy experts using plain language software, and also all the message again were reviewed by another group of target population as well as a multidisciplinary advisory team. We also build our delivery platform system in-house. Therefore, we want to make sure the whole intervention world, we did a 1-week usability testing before we start a pilot study. So a little bit data on the assessment interview that we recruit 30 women who had experience quitting smoking during their pregnancy in the past 3 years. As you can see, they are very underserved, most of them African American and Hispanic population. Majority of them have cell phone rather than home line, and they have 60% of them use text message more than 20 times a day. And the interesting thing we found is that at the beginning we were so excited, we're going to use all those cute text message abbreviation in the content, and they actually told us no, don't do that. They don't want us to text the way they text, because in order to establish the credible source of the smoking cessation program that we provide. So that's why it's very important to work with your target population. We always assume we know what they want. From the interview data, we also derive to understand what type of relapse stressor they have during that experience, which will help us to draft the message that will work. For example, one of the participants explained how her partner smoking impact on her lapse. We also asked about what type of motivator or coping strategy they use that they found helpful in their own experience. Most of them report that they're concerned about their children's health. Also, as well, family and social support will be very critical. For example, one of the quotes from the participants expressed that her mom and her daughter and baby are the motivator to support her to stay smoke-free. After the near-assessment interview, by using that information we derive from the interview data, as well as to review available evidence-based smoking cessation materials such as NCI, ACS, we developed around 200 unique text messages that address the theoretical model we use for this intervention, which is called cognitive social health information processing model that was developed by my mentor, Dr. Susan Miller, which address 5 constructs from decisional balance, distress, self-regulation, belief, and knowledge of perceived risks. So we want to make sure each of the message at least address one of the one of the theoretical domain, also using the information we learned from the patient interview. Once we have the first set draft of 200 message, each message was evaluated by a health literacy advisor software with 2 plain language experts. So the software helped us to highlight where, for example, there are a complex health term or long sentence. So those part of message or the whole message were further revised by the experts, such as here's the sample of the revision. Determination is the key. We changed to willpower is the key as part of the one of the message because determination was picked as such a big word. So the bar chart here, you can see we do a pre and post health literacy advisor software evaluation. You can see the number of these terms decrease. Then we took this, the 200 set of message were randomly assigned to another 30 women that we recruit. Each woman reviewed 7 to 8 messages. Each message was at least reviewed by two different women in this phase to further ask them in terms of a different dimension of how messages are relevant to their personal experience, if they're understandable, and any suggestion for them to tell us how we can make the message better to make it more relevant to their situations. Last but not the least, we have 7 multidisciplinary advisors who review different batch of the final message at this stage. And each message, again, was reviewed by at least 3 advisors across. One of the major focus we will ask them to look at is if each message is addressing their corresponding theoretical domain that we assign to, as well as any other suggestion they would like us to change. So we have clinical psychologists, smoking researcher, and as well as community advisor from the WIC Connect. So really drawing that feedback from different stakeholders, the participants. So that's, we don't want to just like, we have a bunch of researchers putting together 200 messages without being testing before we use it. So this is an illustration of how one message was vetted throughout the whole process. And we did that for the whole, each of all the 200 messages. The feasibility study. So at the end, our final intervention component include a set of prenatal message, which is a way to, so because we recruit our participants during their third trimester for those who quit during pregnancy, and using a prenatal message to kind of engage them in the program as well maintain that relationship with our research project. Once we establish their delivery day, we push 3 proactive system initiate message per day for the first for the 1 month postpartum intervention. So they get 3 different messages per day for the whole month. And we also encourage them to use the Crave and the Lab function, so they can send a message to either Crave or Lab, which will anytime they want, which will ultimately deliver a message back to either help them to cope with the urge to smoke, or provide them strategy to cope with sleep or lapse. We also encourage them, given what we learned from the interview data, we also encourage them to have, to feel free to have phone, to talk with their family and friends, test with them, and to continue that smoking, to stay smoke-free. We do a 1-week check-in to make sure they are still aware after they deliver. Make sure they're still aware of the program, if they have any problem with the service. And we do 1 month, 3-month follow-up assessment to get their smoking and the psychosocial and any other process satisfaction outcome data that will show next. So we recruit 106 participants for the feasibility study, which is actually very, very good, because it's so hard it's very difficult to recruit and work with this very underserved, very stressful population in their circumstance. And as you can see, majority of them are African American, who are single mom, who are low income, low education. Some data I don't have here. Most of them are employee. They are weak. They are using weak service, and most of them have people who smoke in their household. A little bit preliminary claim the lab usage data. So we're very we are very excited to see people are using it. So among the 106 participants, so far we have 58 people text to the crave function, and a number of the frequency of the crave message used per participant range from 1 to 57, and most of them center around concentrate in the afternoon. And for the lab, we also have around 53 people who use the lab function. Most of the time, they use it at evening, which kind of makes sense after the crave. So we are in the process of looking at what type of baseline predictor will be associated to how they use CREM lab, and how their use CREM lab will impact on their other outcome. Another interesting kind of tied to what the previous presenter mentioned is, in fact, whatever they send to CREM lab function, even an empty message, they will get automatic message back. But we start looking at a pattern at how people use that function. People actually using conversational text. People release their emotion. People talk about how they're guilty, how they feel guilty about having a slip. So we are actually also in the process of qualitative review what they saying as the text to the CREM lab function for us to help us to further improve these components. A little bit, among the people who complete 1 month and 3 month assessment, most of them are satisfied, but what I really like is the qualitative data that we got from their interview. So one of the participants said she loved it because she can get it when she needs it most, like someone's there. That helped. She was talking about the credible lab function. However, even though after a very rigorous formal evaluation process, development process we did, we still got some interesting feedback. And I was like, oh my God, we didn't think about that. Someone said, oh, I got a message that told me to take a walk at 2 a.m. with a crying baby at home. So again, that's why it's important to do continue quality improvement for this type of project. We learn and then we move on, we make it better. Okay, so no matter how much they use, no matter how much they like it, the most important thing is the impact on the outcome we are trying to change. So this is among the people who complete 1 month and 3 month follow-up. We actually, their smoking status is actually determined by the CO reading data that we collect in person. So it's a very good objective outcome. And we are very encouraged that we see half of them stay smoke-free. At the same time, this is still ongoing study. We have some people who haven't made to this assessment time point yet. And we have kind of high attrition rate that we haven't factored in for the intent to treat analysis. So given this, again, this is very hard to reach. We still have a high attrition rate. But it was much better than the previous study we have using in-person smoking counseling. And we're very glad to do the formal evaluation as well as getting qualitative evaluation data to help us to continue to improve the program. Several next steps we are thinking to take. Of course, a logical one steps RCT. We should do an R1 for it. And we heard so much about pro and con, the myth of RCT in the past couple of days. But at the same time, just feel bad that we have this very, the message we develop that's sitting on the shelf or maybe sitting on our server while trying to get that R1 hit. So at the same time, we are struggling thinking maybe evidence informed is good enough. Doesn't mean it's evidence-based yet, but we want to do some other scale-up opportunity working with partners, for example, like Text for Baby or other smoking cessation app that we can disseminate this set of messages that for that target population that in other people in the audience or other people's program. And another direction we really want to do is several weight clinic we work with have very high concentration of Hispanic population. We actually have women come to us asking if they can have the Spanish version of it. So we are in process of hoping to partner to adopt the intervention to make it more culturally tailored and linguistically appropriate for the Hispanic population. So we'll thank you for your patience.
We have time for a few questions.
You mentioned that you have data regarding the participants living with other smokers. Mm-hmm. And so I'm curious if you guys are planning to stratify by those that have other smokers in the home.
Definitely. Yeah, from our previous research, we found that living with another smoker or a smoking environment has a huge impact on their relapse. And as a quote, I just present that one of the women say her partner smoked. That really triggered her relapse, definitely. Yep.
Other questions? Oh. A repeat.
One more. I'm interested in home smoking bans and if you're measuring if they have partial ban, no ban, or a complete home smoking ban.
We might not have that data. I'm not sure yet. I don't think we have collect that. Yeah.
Do you recommend?
I think so, but now you mentioned about, yeah. Definitely, yeah. All right, thank you.
Great, good, thank you. Well, we've run to the end of our time, or so close that I know that the presenters will be up here for a few more minutes if you have additional questions for them. But I want to thank you all for your attendance today. Thank you very much.